How does digital workflow optimization impact profitability and quality of care within a practice?
Many times I'm asked how digital workflows can increase optimization, profitability within my practice. I think it's a real good question a lot of clinicians want an answer to. And what I think clinicians need to understand is there's many different levels and many different workflows one can be engaged with. For instance, from an iOS standpoint, I can just merely utilize an iOS and a digital platform in my office. From the simple iOS, I can take another workflow and send it to a mill and potentially mill a restoration, or I can interface with lab partners or other partners in my business and send it out to them for procurement of restorations. With CBCT, it's incredible depending on the volume and the size. There are many things to think about profitability and the digital workflow and optimization with CBCT. But I think it's the ultimate diagnostic tool for doing diagnosis or simply implant planning. So the workflows can be tailored to your needs, be it endodontics, orthodontics, or restorative dentistry. And the profitability cannot be understated. It's very interesting what doctors can do, and they need to be educated and certainly get more information on it so they don't make a bad decision. But increasing profitability with less chair time is a big point about the digital workflow.
How critical is it to have an open platform with practice management software?
I think a very good question that doctors ask, and they're not really sure about, is architecture. What is open architecture? What's closed architecture? Doctors need to realize there's a couple of different things to consider. Closed architecture, which is really one manufacturer, one system. Then there's selectively open, where a manufacturer may engage some other manufacturers or some other software programs, but it's still selectively open. They're still telling you what you can do. I think most important is you have something that's open architecture, to be able to utilize all the different software manufacturers, all the different 3D systems, intraoral systems, and certainly open architecture is important for the future because we don't know what's going to happen, but we would like to believe that these can all get along and communicate with one another. So for any practice, I think they really need to understand the difference between closed and open architecture and embrace open architecture.
How does 3D technology impact a practice?
3D technology for a lot of clinicians seems to be a little out there. Why would I need to have 3D? What they need to realize is 3D is not just about cone beam computerized tomography in placing implants. They need to really think about it. Some of the software programs today, like extraoral images, everyone's doing hygiene. When Mrs. Stiglowitz needs to get bite wings every 18 months to 2 years, what doctors don't appreciate is they can have a CBCT made and do extraoral bite wings, no sensor. They can do that maybe every hour. So a doctor on a routine may be able to utilize their CBCT system for extraoral use with extraoral images like bite wings. It's hugely important that they understand that. Other things that they can do is implant planning software. They can look at periodontal defects. Not only is it dental imaging, but it's skeletal rendering, which is a very powerful tool in looking at things in a 3D image. So 3D is extremely important for doctors to realize it's not just for surgeons. It's just something that they can utilize endodontics, orthodontics, airway, extraoral bite wings. Very important for them to realize that.
What should a doctor consider during the selection process for a 3D imaging unit?
Doctors need to take a couple of things into consideration when they're going to purchase 3D. Important things to be able to think about are volume size, for instance. What are they going to be utilizing their system for? Are they going to be utilizing it as a center in the community? Do they need a large volume where an orthodontist may want to send over a patient? If they don't want to do that, if they're strictly thinking about their practice, why are they using it? For endodontics, for instance, they may want to do a smaller volume. They also need to consider the team and the infrastructure in their practice. Is their dental assistant going to be able to be trained on this? They may want to think about, again, open architecture. Are they going to be utilizing the CBCT information? Do they want to scan models? They can scan impressions. They no longer need iOS. They can make an impression and then scan that and get into a partner and fabricate restorations. So I think that for every individual practice, it's a little bit different. And important things to think about, again, are the architecture, what it's going to be utilized for, and how they best want to be trained for that.
What is restorative-driven implant therapy?
So one of the things I'm most happy about with the integration of CBCT and iOS, intraoral scanning, is I can truly do top-down treatment planning. In other words, if clinicians don't understand that, typically a surgeon or restorative doctor will get a CBCT, they'll look at the available bone, and they'll put the implant in according to the available bone. Well, a lot of times this doesn't work out best because the implant might be coming through the nostril or the ear, and then I have to kind of bail the surgeon out and figure out how to restore this. What's beautiful about intraoral scanning and then taking an intraoral scan, pinning it to a CBCT, prior to pinning it, I can do an intraoral scan of an edentulous area, be it a single tooth, multiple tooth, whatever the clinical situation is. At that time, I can design restorations that fit from a functional standpoint and an aesthetic standpoint. Once those are designed, I import that data into my CBCT or pin it. Then I integrate the restoration or restorations. From there, I can place ideally placed implants according to the restoration, not the available bone. At this time, alarms can be sounded if I don't have adequate bone, if there's not enough height, width, and I can inform the patient of potentially increased time and cost. So top-down treatment planning or restorative-driven treatment planning is huge, and it can be very beneficial. Because when we make these arrangements and we look at this top-down treatment planning, it then can go to the cloud and we can inform our different partners in this of what may need to be done to put in the best possible restoration for Mrs. Stiglowitz from an aesthetic and functional standpoint, not just where the bone is.
What imaging technologies are used to assist in the integration of 2D and 3D and CAD/CAM?
What kind of imaging technologies can we use to integrate or interface with 2D and 3D? As a restorative doctor, prosthodontist, I'm in the 2D world a lot. I appreciate the 3D world, and I realize when I need to utilize that, but at times I'm going to probably utilize 2D a lot more. For instance, in extraoral images or extraoral bite wings, which is a phenomenal potential with these different systems. I'd like those to be in 2D. I can use 3D and it's reformatted into a 2D image. So this is important for doctors to understand. Do they need 2D? Once they have 2D, can they upgrade to 3D? Can they use 3D and get a reformatted 2D image? So I think it's very important if you're looking at the manufacturer to specifically find out what 2D looks like on a 3D system, or to start slow with 2D and slowly be able to upgrade into 3D. And then to make sure your management software can handle both those different potentials and utilize those in your practice on one platform.